what's the clinical criteria that's necessary to be eligible for these different types of care. That's something that we could discuss over the phone. We don't need appointments. People just call in and we try to find them an advocate to speak to. We give information about Medi-Cal planning, eligibility, and Medi-Cal recovery. We also, one of our frequent calls is about skilled nursing facility and residential care facility for the elderly, admissions and transfers, as well as discharge issues. So it's very common that facilities are trying to kick people out and they need to know what their rights are. So we'll advise them on that. Our staff is made up of lawyers, social workers, and advocates. And we also give people information about their rights in long-term care facilities, such as nursing homes, RCFEs, also known as assisted living, and continuing care retirement communities, also known as CCRCs. We have a lawyer referral service for elder abuse in long-term care facilities, and also estate planning for Medi-Cal eligibility. We do consume community education like this. We do presentations and we create publications that can be distributed and shared. We also do policy and administrative advocacy. So from the phone calls that we receive, we collect what the trends are and figure out what are the bigger issues. How can we solve some of these things systemically? So we'll carry legislation or sponsor legislation. We work with the different government agencies to try to improve the different systems. So, for example, we work with the Department of Healthcare Services, give them feedback on new policies, new letters, things that we're seeing on the ground, issues that we're seeing in the community. So we do that with the Department of Healthcare Services for Medi-Cal, or CMS, which would be the Center for Medicaid and Medi-Cal Services, Medicare and Medicaid Services. And also the administrative agencies that oversee nursing homes and assisted living. And when none of those types of advocacy work, sometimes we are forced to pursue litigation. And so there's been cases where we've sued the state for not doing their jobs and enforcing the laws that they're supposed to use to protect long-term care consumers. So today I'm going to talk about Medi-Cal. So this presentation is relatively short. Just Medi-Cal is a very complicated area. And sometimes when we do presentations for professionals, sometimes we do like an intensive 3-hour. So I'm going to be very general, but if you have more questions, you're welcome to contact me, or you can contact our office and we can give more information. So Medi-Cal is California's Medicaid healthcare program. Sometimes people will hear Medicaid. Medi-Cal is California's version of Medicaid. It is different than Medicare. Medicare is an entitlement program run by the federal government, whereas Medi-Cal is run by California for people who are low income. The program pays for a variety of medical services for children and adults with limited income, and it's supported by federal and state taxes. What does Medi-Cal cover? Outpatient services, so things like doctor's visits, emergency services, hospitalization, mental health services, prescription services, laboratory, physical therapy, skilled nursing care, in-home care and supports. So there's quite a few. They call them home and community-based services. Sometimes you might hear of them as Medi-Cal waiver programs that provide supports. We will have somebody doing a presentation at a later time going into more detail about that. And then also transportation is covered as well for people who are in managed care. So managed care is another kind of complicated aspect of Medi-Cal, because even though Medi-Cal is paid for by federal and state taxes, and it's a state agency, what Medi-Cal does is they have managed care plans. So they contract with third-party healthcare providers to deliver the services to Medi-Cal beneficiaries. So what some people may find, for example, if they're in Medi-Cal, they may be enrolled in a managed care plan. So in San Francisco, there's I can't remember, what is it, Healthy San Francisco, Healthy SF or something like that. And then there was Anthem. So sometimes the plans change, but usually you could call Medi-Cal to find out who your managed care plan is, because they're the ones that are going to deliver the services. Are there asset requirements for Medi-Cal? As of January 1, 2024, California eliminated the asset limits for all Medi-Cal programs. It's the first state in the country to do so. So before, I would maybe have 5 slides explaining different assets that you could or couldn't have to be eligible for Medi-Cal. And now that is no longer the issue or the case, because there is no asset limit for Medi-Cal. So you could have $1 million in your bank and potentially still qualify for Medi-Cal as long as you meet the income requirements. And this includes programs for people 65 and older who are blind or disabled, and those seeking long-term care services. There's no longer an asset limit. So this chart may feel a little overwhelming, but it is a good way to kind of see all in one place what the most common Medi-Cal programs are that apply to people who are aged and disabled, and that is the population that CANHR serves. So MAGI, which stands for Modified Adjusted Gross Income, that is actually a Medi-Cal program. It's for people who are 19 to 64 who do not have Medicare. An individual who would be eligible for this program must have less than $1,732 a month in countable income. There's no share of cost for this program. Medi-Cal, if you're under that amount, you qualify for this program, and Medi-Cal pays for all Medi-Cal covered services, but you cannot use deductions to reduce your countable income. In other programs, you'll see that you can use healthcare premiums to lower your countable income. There's no asset limit, and this is a common program for low-income adults. There used to be, when there was an asset limit, transfer penalties. That's no longer relevant, but Medi-Cal used to penalize people for transferring money, but now that's not the case because there's no asset limit, so that's not an issue going forward. Then there's the Age, Blind, and Disabled Federal Poverty Level Program. For this program, you must be 65 or older, or blind, or disabled. The income limit is the same as the program above. However, for this program, you can reduce your countable income by purchasing supplemental health insurance premiums. So for example, if your income was at $1,800 a month, that would put you slightly over the 1732. So a strategy we often give to people is to figure out how much you're over and purchase at least that much or more in healthcare premiums, like a dental plan or a vision plan. And that will get your countable income below the limit so that you can qualify for this program, have no share of cost. And I'll explain that later. And then the other thing to consider is some couples may be eligible for additional income protections through spousal impoverishment if they're enrolled in certain home and community-based services programs. So, for example, if someone calls my office and they say, we're married, we applied for Medi-Cal because we needed in-home supportive services, but our income's over the limit, so we have a share of cost. I may try to see if they might be eligible for spousal impoverishment protections. Medically Needy is the program where someone would have a share of cost. This is for people who are 65 or older, or blind or disabled, who are above the limit that you see above that, and the 1732 for a single person or 2,352 for a couple. So if they're over that amount, they're going to end up in this medically needy category. And I kind of describe it as more of a kind of catastrophic coverage. You may have a high share of cost, and if you have a high share of cost, you're probably not going to meet that share of cost each month. So Medi-Cal isn't going to kick in, and you'll have it. It may be useful to you if, for example, in 1 month you have really high medical costs. Then it would make sense you would pay your share of cost, and Medi-Cal would kick in. So if somebody isn't medically needy, that's when we may try to figure out, is there a different program that could benefit them more? Can they be eligible for another program? And we at CANHR try to help people figure out if there is anything. There isn't always another option, but sometimes there is. And long-term care Medi-Cal would be what you would be on if you're physically in a nursing home. There's no age restrictions as long as the applicant is in a skilled nursing facility. And in this program, beneficiaries are going to pay almost all of their income as a share of cost and keep a small personal needs allowance of $35. However, if they're married, there's actually spousal impoverishment protections, which may allow them to keep more of the income. So I know that's a lot of information, but it is good to know the different limits, because so many times we have people calling us that they were denied or they have a large share of cost and they think this can't be right. And sometimes it's not right. And so it is good to know that these are the limits. But again, if someone had a specific case, we could go through it with them and help them figure out what their share of cost might be, if there's any strategies they could use to eliminate a share of cost, or if there's a program they might better fit into than the one that Medi-Cal placed them in. So I've been talking about share of cost a lot already, but this is a clear explanation, hopefully. So if someone's countable income is above $1,732 for an individual or $2,352 for a couple, they will have a share of cost. This is the amount of money a person must pay each month towards medical related services, supplies, or equipment before Medi-Cal will begin to pay. So Medi-Cal will so you want to think of it like a monthly deductible, and Medi-Cal will help you figure out the share of cost based on the total countable monthly income. People may be eligible to purchase supplemental medical insurance to get their countable income down. A share of cost example. So say, for example, someone has $1,900 a month in gross unearned income. The way they're going to do the calculation is they're going to subtract $20. They call it an any income deduction. So they get $20. And then after that, that's what they call their countable income. So for this person, in this example, it would be $1,880. And then unfortunately, there's something called a maintenance need. So when you have a share of cost, the way they determine what your share of cost would be is they look at your countable income and they deduct $600. And this is what they say a single person needs to live on in California a month. Now, I know that sounds ridiculous, but that is because this number has not increased since the 80s. And so it's obviously not sufficient, but that is the calculation. So in this case, this person's monthly share of cost would be $1,280. So that person would need to pay out of pocket towards their medical expenses before Medi-Cal kicks in. So that's if they even have $1,280 in medical expenses. Say they don't have that much. Say, for example, they only went to the doctor and it wasn't, I don't know how much a doctor's visit would be without coverage, but let's say, just for the example's sake, that the visit was $100. So then in that month, they would just be paying $100 out of pocket. Medi-Cal would not kick in, and they would not have to pay $1,280, but they would just be paying their amount of $100 in this example. And so in that month, Medi-Cal would not kick in. So you have to meet your share of cost for Medi-Cal to kick in. But you don't have to pay this amount if you don't have that much in medical expenses. And I know this concept is usually difficult for people because the equation doesn't make a lot of sense, that it's $600 to live off of, and why that there's this, they call it like a share of cost cliff, right? It's because you're at $1,900 and then for some reason you only get to keep 600. Whereas if your income was 1,732, you get free Medi-Cal and you don't pay anything. So one way you can eliminate an unwanted share of cost.
Excuse me, Pauline, I just wanted to, sorry to intervene. Well, questions and answers will be discussed after the presentation. So please, you can send your question in the chat box or after the presentation. So we'd like to do that way so we are able to have a thorough presentation first. Thank you, everyone. Okay, thank you, Pauline.
So in this example, this person's name is Sylvia in this example. And so with that person, actually this number is old here. So 1677 was the old number. It's actually 1732. So what you want to do is, if you look at this last, so this person's countable income was 1880, right? So what you're going to do is from 1880, that's the countable income, you're going to subtract 1732, which is the limit. So she's $148 over. So what you would want to tell this person with this share of cost of $1,280, it would make much more sense for them to purchase healthcare premiums in the amount of $148 and then have free Medi-Cal instead of having to pay this large share of cost that Medi-Cal may never kick in, because it's unlikely someone's going to have $1,200 in medical expenses every month. So that is something to consider. When someone's over by a couple $100, it makes more sense to reduce their countable income by purchasing healthcare premiums. So healthcare premium would be dental, vision. Sometimes people buy a Medicare drug plan, or sometimes there's Medicare supplements. You could also have long-term care insurance, and they do have a full list in the Medi-Cal eligibility procedures manual. So when I send the slides, it'll have the link on there that you can refer to. So options for meeting the monthly share of cost. So I talked about earlier reducing the share of cost. Sometimes people may not, maybe the gap is too large and they can't purchase enough healthcare premiums to reduce their share of cost. How do they meet their share of cost to have Medi-Cal kick in? So in this case, if this person's share of cost was $2,080, the beneficiary of the medically needy program must have out-of-pocket expenses equaling to the monthly share of cost before Medi-Cal will cover the cost of their other services or supplies. So things that you could pay that would help meet your share of cost would be if you're purchasing medical equipment, prescription drugs, medical services, other medical costs that Medi-Cal does not cover, such as providers that do not take Medi-Cal, Medi-Cal procedures or treatments denied by Medi-Cal, in-home supportive services caregivers. So for example, if you have a share of cost of $1,200 a month and you have a caregiver and you're approved for so many hours, you may end up paying them for the services they receive. And then once you've paid them your share of cost, Medi-Cal would cover the other services that you receive. There's also another way to get additional hours that are prescribed by a doctor to that you pay for out of pocket to help you meet your share of cost. That's a little bit more complicated of a technique to get to meet your share of cost. But if somebody has high care needs and they don't get enough in-home supportive services hours to meet their needs, that could be an option, especially if they have a high share of cost. Now, I talked about something called spousal impoverishment earlier, and I said to be eligible for the spousal impoverishment in the community, you would need to enroll in home and community-based services. These are programs that offer an alternative to nursing home placement for people who want to stay in the community. Services include caregiving, personal care services, help with chores or preparing meals, protective supervision, in-home nursing care, case management, and home modifications. Not all services are available in all counties, and you need to apply to each program individually. So another complicated thing about Medi-Cal and home and community-based services is the feedback that we hear and that we experience is it's difficult to navigate through the different programs to figure out how to apply, what the eligibility criteria is. So we do help people with that as well. And then the benefit also, if there's a married couple and one person in the couple needs these services and they're high needs, there's extra income allowances if you have one spouse on Medi-Cal and they become eligible for one of these home and community-based services, whether they're enrolled or on a wait list. Now, this is another concept that I will say is pretty complicated. Many of the professionals that I work with struggle to kind of to understand the concept of spousal impoverishment. So if it's something that sounds a little confusing, that's very common. And sometimes people need to read about it. We have a fact sheet about it called spousal impoverishment. And sometimes once people read about it in more detail, they have a better understanding. So if it's something that may benefit someone, there's a fact sheet or they could call us. Okay. Does immigration status affect eligibility? Medi-Cal has been expanded in the last couple of years through legislation to include individuals 26 to 50, regardless of immigration status. Individuals will be eligible for full scope Medi-Cal, and this includes all the services listed here. So the one thing people are concerned about with immigration is something called public charge. And I can't explain too much about public charge, but it is something that they're not going to consider participation in Medi-Cal, except for if someone's in a nursing home. In that case, they would consider it for public charge. But for regular community-based Medi-Cal, where you're living in the community, it's not going to be part of a public charge determination. And if you do have concerns about public charge, we did include resources here because it's not CANHR's area. So I wouldn't really be able to speak more to it, but we do think it's good for people to know. And then how do you apply for Medi-Cal? You can apply by mail. Some people use a single streamlined application that's available on the Medi-Cal website. There's also another application called SAWS 2+, which is commonly used as well for people in the community or going into a nursing home. You can apply by phone, fax, or email. You can contact your local county office to find the number, to find the phone number. Sometimes there's different, for example, LA County may have several different offices and they want to give you the office that's closest to you. So it's good to call the county office to find out what specific, if there's a different office you need to call. You can also call Covered California. You can apply online at Benefits Cal, or you can apply in person. Okay, and then once someone has Medi-Cal, a concern people have before applying or once they've been on Medi-Cal is they've heard about a program called Medi-Cal Recovery. And we used to get so many calls. people being concerned, is Medi-Cal going to take my home now that I'm on Medi-Cal? So one of the things we try to remind people is Medi-Cal doesn't take people's homes per se, but they do seek repayment from your estate after death if the cost of services that were paid for by Medi-Cal, only if they use the following benefits. So they seek to be repaid if somebody was in a nursing home, in an immediate care facility for the disabled, in certain home and community-based programs, and if they were in one of those programs or in a nursing home, related hospital and prescription drugs can also be part of what services Medi-Cal can recover for. So Medi-Cal recovery only applies if you use the following benefits, and if you have anything in your estate, and also if your estate is not subject to probate. So there's a lot of ifs. There's a lot of ways you can avoid Medi-Cal recovery. And if somebody's estate is not subject to probate, then there will be no recovery. So that's a new law. CANHR was a sponsor of this legislation that went through before it was much easier to try to be repaid for services that people received, but now it's much easier to prevent Medi-Cal recovery. So if you do have property and you're worried that someone is going into a nursing home or they're in a certain home and community-based services program that would be subject to Medi-Cal recovery, you can make sure that their estate doesn't go through probate. So if they have a home, for example, they could put it in a living trust or joint tenancy, or pay on death accounts, life estates, mobile homes, and other manufactured homes. None of that would be subject to Medi-Cal recovery. And then also, if it's considered a small estate, then it would not be subject to recovery either. Or if there's a surviving spouse or registered domestic partners. So there's a lot of ifs. So we do have a Medi-Cal recovery guide on our website. This is another kind of more complicated topic that there's, like I said, there's a lot of kind of if this, then that, or if this, then that. So there may be many reasons why somebody would not be subject to Medi-Cal recovery, or reasons they would be, and you can avoid it by trying to avoid probate. What is probate? Probate is a court process where a person's relative seeks appointment as an estate administrator of the deceased person's estate if the deceased died without a will, a living trust, or if there are no beneficiaries designated on accounts or deeds. If the person's gross assets, accounts, car, safe deposit box, etc., are below 1,084,500, then their heirs can access those assets through an affidavit process without court order. So what someone may want to do is contact an attorney, and they can tell them that they want to avoid Medi-Cal recovery and they want to avoid probate. And they can do an estate plan to make sure that their estate is not subject to Medi-Cal recovery or probate. So I know that was a lot of information in a short amount of time. And if it didn't all stick, that's actually to be expected, because I've spent many years learning about this, and I learned something new every day because it's a complicated system, unfortunately. Any questions?
Okay. All right. Thank you so much, Pauline, for your presentation. And so today's presentation was focused on eligibility and issues. And there's going to be a following up presentation, which will be held September 17th from 1 to 2:15, the same time. Speaker from CANHR is going to talk about Medi-Cal with home settings. like a long-term eligibility with Medi-Cal, including IHSS services. So there's going to be a part 2. But today's presentation, Pauline was covering a certain subject. So we are going to, Pauline's presentation was actually recorded, and we are going to share only the Pauline's presentation for our attendees in later time. And well, we are going to have a Q&A and discussion, and then Jeremy is going to facilitate it. Okay, thank you.